Honorable chairpersons, respected professors, and dear colleagues, Assalamu alaikum, and a very good evening. This is Dr. Mehdi Hasan Mazumder. I'm working as a specialist cardiac surgeon at Green Life Hospital. My presentation is successful surgical management of a patient with atrial septal defect, mitral valve regurgitation, and coronary artery disease at Green Life Hospital. Here is our surgical team. This surgery was led by Dr. Noordin Mohammad Jahangir, senior consultant, cardiac surgery, Green Life Hospital. 41 years old male came to our department with the history of shortness of breath, palpitation, and generalized weakness. He was pre-diagnosed with atrial septal defect, secondum, severe mitral valve regurgitation with type 2 diabetes mellitus, and hypertension. After doing coronary angiogram, we have got to know that he has got double vessel coronary artery disease. His hemodynamics were stable. Hematologic and biochemical analysis were in acceptable range. On echocardiogram, we have found left ventricular ejection fraction 47%, pulmonary artery pressure 37 millimeter mercury, large ASD with left to right shunt. A bend was noted in right atrium. Severe mitral valve regurgitation with both anterior and posterior leaflets were thickened. On coronary angiogram, we have got LD has 6 to 7% stenosis at osteoproximal segment, diagonal 80% stenosis in proximal segment. He has normal LCX. RCA was 100% occluded from proximal segment, getting retrograde flow from left side. Coronary artery bypass grafting was done. Were off pump beating heart, lima to lead, reverse saphenous venous graft to diagonal, and PDA. Both leaflets of mitral valve were thickened, retracted, and fused subvalvular apparatus. Through ASD, mitral valve was excised and replaced with St. Jude's 27 mm bileaflet mechanical valve. ASD closed was done by pericardial patch using 5-polypropylene with continuous suture. Total bypass time was 94 minutes and cross clamp time was 74 minutes. Here's the X-ray. The X-ray shows cardiomegaly. On echocardiography image showing that large ASD band in right atrium and MR jet. On CAG showing 100% stenosis in proximal RCA, 6 to 7% stenosis in proximal segment of lead, and 80% stenosis in proximal part of diagonal, first diagonal. Intraoperative image showing the atrial septal defect. Here, mitral valve replacement through atrial septal defect. Atrial septal defect is being closed. Coronary artery bypass grafting, and 3 graft has been given, lima to lead, venous graft to PD and OM. Discussion. Atrial septal defect can coexist with mitral regurg, and the etiology of mitral regurg could be congenital and acquired. Furta and colleagues proposed a special pathophysiology called the ASD-MR complex, which is similar to aortic regurg, ventricular septal defect, VSD-AR complex. They proposed that abnormal left ventricular motion secondary to right ventricular volume overload leads to friction between the mitral valve leaflets, resulting in fibrous thickening on the medial aspect of leaflets, consequently an incompetent mitral valve. Whatever the etiology, over time the combination leads to right ventricular volume overload, pulmonary hypertension, and right ventricular dysfunction. They argue that a backflow of blood into the right atrium leads to widening a patent foramen ovale and consequent left to right shunt at the atrial level. The most disturbing symptom of the patient was palpitation, and the fear was that he could have developed atrial fibrillation, which could be a negative prognosis factor. The echocardiographic and surgical assessment of a mitral valve showed fibrosis and thickening of posterior mitral valve leaflet with fused subvalvular apparatus. Hence, mitral valve in the patient was not favorable for a valve repair. Here are the references. The result, perioperative and postoperative course of patient was uneventful, and the patient was discharged from hospital on 8th postoperative day with good fitness, and he was doing well in last 1 month follow-up. The conclusion is combined surgical treatment of atrial septal defect with mitral valve regurgitation and coronary artery disease has good outcome. Thank you very much.